Okay, so I figured it out. I think I'm recording. I should be recording, but okay. So, we're gonna talk about Dr. D's midterm outline. I kind of want to go over it, make sure we all kind of have the same things, discuss like all the ideas we've already like talked about. So at least it's like you had one full blueprint review before you continue doing more of your studying. So, yeah. Is there any questions before I start? No. Okay, so yeah, like I said, anybody who just came, put your SSC ID number into the chat, and we can start. So, like I said, I typed it all up because I love typing things, and I like having things all in the same place. So, I definitely like to have things, typed. But the first category that I saw in her blueprint was that she put chapter 1, and there's certain slides that she wanted to go over. And I know there were, one of the major ones was, what are the major changes in healthcare in the 21st century? Do we remember the 3 changes that came up that we should know?
Hey, yeah. So it's basically the patient-centered care, technology, how it's advancing, and how there's more active participation of patients, personal responsibility for health.
Yes, so those are the 3 major changes, and also for me, something that helped me is I wrote at the top that like what are the roles of like a community nurse. So the community nurse is to promote health, reduce risk and injury, and then prevent disease and disability. So one of the major changes that we saw was that we have development of patient-centered care. And I remember Dr. D was saying that one of the things that we should always put first is their cultural traditions. Like we also want to take into account, right, their personal preferences, their values, their families, their lifestyles. But I remember she said that we should put cultural traditions as our priority when it comes to developing patient-centered care. We also have the increased use of technology. Now, does anybody want to explain the difference between, since she identified these 2 terms as important, health information technology versus telehealth, or even just wants to say what the definition is of either?
Well, I know for telehealth, it's basically providing like care and assessments virtually, so making it slightly accessible to patients.
Yes. Does anybody have anything else they want to add to the idea of telehealth? Well, yeah, it's long distance clinical healthcare. So I remember Dr. C said that's really important because a lot of people don't have access to healthcare from their local neighborhood, right? It might be an hour away depending on where you live. So telehealth was a way to support long distance clinical healthcare, like you said, Caroline. And also health information technology, please correct me if I'm wrong. The way I understood it by looking at the definition was that it said it was a comprehensive management of health information and its exchange between consumers, providers, government in a secure manner. So the way I thought about it is like it's a place where all of your health information is put, and it's where you can see it, your government can see it, your insurers and your providers. I don't know if anybody else has anything to add.
Yeah, I think you mentioned all the points that she would like us to know.
Okay, yeah, and I think would be that electronic health records would be an example of that, right? Because it has everything on there. Like it has all of your information, your list of like providers, your family members, what insurance you have. So I think it's just trying to tell you like how they use or how they secure health information using different sorts of technologies. And the next really important one is the increased personal responsibility. So the three changes as like a summary is we have the increased idea of patient-centered care, increased use of technology, and then this idea of increased personal responsibility, right? Because even though, yes, it's our job as like a nurse to educate them on their health, and as I said, as a community nurse, we want to promote health, we want to reduce risk, and we want to prevent disease, we also need to know that they're in charge of their own health. So they need to do things to take care of themselves and prevent some of those illnesses or take their prescribed medications, or if their cultural traditions do not imply that, maybe herbs or different things that doctors could say correlate with their beliefs but also can help manage their symptoms. So I definitely think this is really important because we are all responsible for our health even though we have access to healthcare and things. As I said, if you didn't already, please put your SFCID number into the chat. But yeah, so those are the three major changes in the 21st century that she said we need to know. Development of patient-centered care, the use of technology, and increased personal responsibility. Now, the next thing she wanted us to know is social determinants of health. What is a social determinant of health? Another way of saying determinant is a factor or social factors that affect health. What are some?
Transportation.
Yeah, that could definitely affect your health. What else?
Education.
Income, literacy.
Anything else?
Culture.
Okay. Gender. Right? Okay, that's a lot of things. Anything else?
Environment.
Access to treatment.
Yes, all of those things. Anything that can affect your ability to get health care is a social determinant of health. Factors that can affect health. So this definition is social conditions in which people live, their income, their social status, their education, their literacy level, their home and work environments, their support systems, their gender, their culture, and availability to health services. So like for me, the way I think about this definition is like kind of anything that could affect me as a person from getting access to health services or taking care of myself, right? I said transportation, my education, my income, my support systems, my access to knowledge, like all of those things affect how you as a person or as I as a person can receive and understand my health, and even health literacy, right? The idea of how much do I really understand or can read, write, or just comprehend based on the things that they say. So I think it's really important to kind of think about like all these different things that affect, instead of like thinking that as a hard definition, because as she said, it's going to be more application. But I love that everybody at least had an idea, which means we're on the right track. I also thought it was important to write down the term health disparities. Does anybody remember what health disparities are?
It's like significant disadvantage, like affecting certain groups of people. So for example, like the maternal mortality rate in the US.
Exactly. I love the way you phrase that. Yeah, it's differences in healthcare received by different populations, and that promotes like health disparities, right? If I'm from a different community, I might have certain health disparities or things that might affect me receiving my healthcare or risk than another population per se. And then I did remember on that slide, she said that the CDC says there's usually three issues when it comes to health: the healthcare practitioners, the community, and then the clients. So there's different things that impact it, right? Like how are the healthcare practitioners looking at the health or a health crisis? How is the community responding to a health or a health crisis? And how are the clients responding to that? So those are really important things. Anything anybody wants to add to anything?
No, no, I think that covered it.
Okay, so the next things are principles of public health. Now, I was trying to think about this. I know we have to know all, like, 8 of them, which are on 2 slides, but I think it's also good to think of it as like, okay, well, what are some things that I would need to know as a public health nurse or a nurse that's caring for a community? So what are some things that you think would be really important that I should have as a community health nurse, or what I should do?
One quick question. Are we supposed to know all 8 or 4?
The way I saw it on the blueprint was she put both slides. So it would have this, I think the first slide had 1 to 4 and the other one had like 5 to 8. So I think we need to know all of them.
Okay, thank you.
Well, I like to think of it as the idea, like going back to the model of what a community health nurse is that we promote health, we prevent risk factors, and we also prevent disease and disability. So our client or our population is our priority, right? That's what we're looking at. And it's usually a population because we are community health nurses. And our obligation, which is the second one, is to achieve the greatest amount of good for the greatest number of people. We also, as public health nurses or community nurses, our goal is primary prevention. And what is primary prevention?
Like educating the patient?
To prevent disease.
Preventing, immunize.
Educating, getting immunizations to prevent diseases or viruses.
Yes, because primary prevention means they don't have anything, and we want to prevent them from getting it. And as you all said, we can use education or immunization. Those are really big common ones in order to help prevent. So education on like mortality relates or like related statistics if it relates to a population at increased risk for mortality when it comes to like labor and delivery and things like that. So definitely primary prevention. We also, as a public health nurse, focus on strategies that create a healthy environment, that also a healthy social environment and healthy economic conditions in which populations can thrive. Because remember, our focus is the population. We want the best for the population. So even if we forget all of these, I think a good like mindset for the test might be, okay, well, I'm a community health nurse. I work for the community. What are some things? I don't want anything that's going to harm them. I only want good things. And we want primary prevention where we don't want them to get anything. So how can we do some of those things? And we can do that by focusing, having strategies that have good and healthy environments. And as number 6 says, a public health nurse is obligated to actively identify and reach out to all who might benefit from an activity or service. So if there's a flu clinic, right, in your neighborhood, it would be the nurse's job to promote that and say, hey, everyone, we're giving out local flu vaccines if you want to come get one. We also, number 7, another principle is optimal use of available resources and creation of new evidence-based strategies is necessary to ensure the best overall improvement of health populations, right? Everything is evidence-based practice for us. So even if we didn't remember that, we know as a nurse that we need to follow evidence-based or the most up-to-date things and research that has indicated the best possible health outcomes. We also want to collaborate, right, with other professions, right, like different providers, with populations, different organizations, and stakeholders, because all of these people make up the community, and if we can get the more people we get involved, the better the health of the community will be, right? Like, if you have a local community, like I have a local volunteer fire department. We're one of the few local volunteer fire departments left in a neighborhood. They don't get paid. But our community came together, worked with different people, worked with like the local borough commissioners, and we are able to keep this because our community actively does things to keep that, and it's collaborations with other people. And you might be able to think of some other community resources or community organizations that you might have in your own community that are as a result of different people communicating with other people. So I think even if it's hard to memorize things, I think memorizing is like the worst thing that you can do. I think it's better to understand and then let the memorization kind of fall in. So if you know that as a nurse or a community nurse, my goal is the population, my goal is to do the best to promote health and provide the greatest amount of good for the greatest amount of people, that might help finding or narrowing down the answers much more easily, right? Like if Dr.D said, what's my role as a nurse, and option A is, oh, only help one person at a time and exclude the rest, that wouldn't be the answer. So I think that might help. And a stakeholder, which is one of the people you might collaborate with, it just means that they have an interest or concern about something. So maybe an investor in that community, like mine, maybe the fire department, that maybe they work in relation to a certain investor or a certain facility that is a stakeholder because they have an interest in that. So anybody who has an interest, like we are students of St. Francis College, if something were to happen to St. Francis, we would be stakeholders because we have an interest or a concern about something that we actually have assets into. This is assets into our education. Any questions with that?
Very good.
Okay. So another thing that she said is that we need to know from pages 4 to 7 is the definition of equity. So that just means providing equal care without discriminating against gender, race, sexual orientation, and socioeconomic status, right? Like we should be giving the same amount of resources, the same amount of care, the same type of care to anybody, regardless of who they are or where they came from. Now, the next thing that we have are symptoms of selected mental health disorders. And one of them is risk for suicide. So she could easily ask us a bunch of different risk factors or put a true or false or even say, okay, which of the following or select all of the following that are risk factors. So if you, as we learned in psych, right, like what are some risk factors or what can put a person at risk for being suicidal?
A previous attempt, history of depression,
Lack of employment.
Okay. Anything else?
substance abuse,
Lack of family support.
Okay.
Schizophrenia.
Okay.
Maybe they're going through a divorce.
Right. No spouse or loved one or a partner.
A disease, illness, a terminal illness.
Good. These are really, really good. Anything else anyone wants to add?
I remember there was 7 or 8 different risk factors between men and women who's more who's more to attempt suicide to go through it. Is old age or and the adolescence age are risk factors?
Yes. And what you were saying about the differences in the sexes is that males are more lethal in their attempts for suicide, but females are more likely to go through with an attempt. So that's the thing that I heard you mentioning, and you are right. It increases with age, so elderly are more at risk for suicide as well as adolescents. Those are the 2 high risk populations.
I thought it was men would succeed in suicide more than women. There's more women, but I thought it was the other way around.
More women have more attempts. They have more attempts, but the men are more lethal. So
Yeah,
you're right. They'll succeed more than men, but the females are actually gonna do it more. So like the females will take less lethal, right? So they might try an overdose or drink pills, whereas a man might use a gun. So they're more lethal and more successful. You are right, but females make more attempts statistically.
Yes. And also non-religious are more suicidal risk than religious people. Like atheists would be more at higher risk of suicide than a religious person.
Yes. So she said no sad persons. So SAD persons, the first S stands for sex, and that's what we were talking about. Males are more lethal, so they succeed more, but females make more attempts, and their attempts are less lethal. The A in SAD is for age, so increases with age, so elderly, but also adolescents are the high-risk populations. D, depression, right? Anytime someone's depressed, there's an increased risk for suicide. Now, I have a question for you all, which is, does the risk for suicide increase as the depression gets worse?
Yes.
Yeah.
As the depression gets worse or as the depression gets better?
As the depression gets better.
Because you have more energy.
Yeah. Yes, I know she could pop that question up because she was our psych teacher, but yes. So not when the depression gets worse, the suicide risk increases, but the risk increases when actually our depressive symptoms get better because, as you all said, you have the energy, right? If you're really depressed, you have no energy to do anything. But when that energy level starts to increase, you could actually fulfill or actually go along with that plan. Another thing with the P in persons is previous attempts. You're more likely to do it if you've done it in the past. E for like ethanol, but alcohol use and drug use. Rational thinking loss is the R. S for like no social supports or like no spouse. O for an organized plan. And also no spouse. You could do no social supports. You can kind of reverse them. And S for sickness, right? Like chronic illnesses. Other things include, as a lot of you said, no religion, having a family history, a loss of any kind, socioeconomic status, whether that be high or low, race. Caucasian is the highest, but then Native Americans due to risks of alcoholism, psychiatric disorders like someone said schizophrenia, and insomnia. But I know she did say pay close attention to the SAD person scale. Another thing is I thought it would be important. She didn't necessarily say this, but I added in the suicide precautions because she could ask us something along the lines of what should we do. So, if we suspect someone is suicidal, what should we do?
And put them on a safety watch. Also make sure that the surrounding is free of things that they're going to harm themselves.
Ask them if they ever thought about hurting themselves.
Yes. So if we definitely get that answer that they are suicidal, we want to do those precautions as Anne said, but we definitely want to first ask them are you thinking about harming yourself? And then what do we do?
Ask them if they have a plan.
Also make sure they have a one-to-one. Someone's watching them all the time.
Yes. Denise, were you going to say never leave them alone?
Yes.
That's really good too. Yeah, all of those things. I mean, I know she didn't specifically say it, but it could be a fair question being that we are talking about the risk factors and we are going to go into the signs and symptoms of mania and depression. And she also said we should know certain interventions and suicide precautions or suicide interventions are something that we would implement for either of those patients. So I definitely think it's good to go over. And what might be some cues that lets me know, verbal or nonverbal, that they might be at risk for suicide?
They can say like I can't take this anymore, or I don't want to leave anymore, like that type of phrase.
Okay.
Giving away like important things to them.
Like giving away possessions, yeah.
Changing their appearance.
Yes, a change in their appearance, which might seem like a good thing, but it's actually not. What else?
When they make comments about the world is better off without me.
I was also thinking like putting their affairs on us, or maybe they're talking about let me get like my will together, let me, start getting money and putting it in different accounts. If they just start randomly doing that, that might be also a sign that, hey, they might be thinking about suicide. Okay, So the next thing is, since we're talking about suicide, she wanted us to know the symptoms of bipolar disorder, specifically depression and mania. So if my patient is depressed, what sorts of like signs and symptoms do I expect them to exhibit?
Like lack of energy.
Okay.
They might lose interest. They don't want to eat.
Okay.
Their self-esteem is very, very low.
Mhm.
There's a word for this, but I forgot. But like a loss of interest in their usual hobbies or life in general.
I think that word is like abolition or something. I'm not too sure. That I have to look up.
I think you have it there in Hazonia.
I do. Oh yeah, okay, it's that one. Yeah, so there's that. Thank you. I didn't see I had that word there. But yeah, loss in pleasurable activities. Are these people gonna be like happy at all? Like, are we gonna see them really be,
No, they're gonna feel pretty hopeless.
Yeah, I feel like anytime I think of a depressed person, even if when I see the symptoms, I'm thinking everything negative. You know what I mean? Anything that seems sad or they don't have like a good self-esteem, anything that's the opposite of like happy and joyful. And I feel like when you know the symptoms of depression, you also can know the symptoms of mania because they're the direct opposite, right? So someone who's depressed feels sad and worthless, but someone who's manic has these delusions of grandeur. So they think they're like the best thing. So I definitely think knowing one helps you know the other. But yeah, some things are like they have poverty ideas, like they really have nothing going on. They're not really taking care of their hygiene. They might be eating too much or too little. So that's why it's really important as a nurse to be watching their like intakes and outputs and making sure they're eating if they're not, making sure they shower or get changed if they really haven't. Also some other things are suicide precautions, right? Because she said always associate if they're depressed, they could be at risk for suicide. So we want to keep that in mind. And then, as we mentioned before, do all of those suicide precautions. Also something is that depressed people tend to they can't really make choices and they don't really like a lot of things going around so we want to decrease their stimuli, decrease their choices, make sure we're clear with our communication and be present. And if they're suicidal, make sure we have all those precautions that we mentioned before. What about a manic client? What sorts of signs and symptoms do we expect for a patient who's manic?
Super high energy.
Delusional of grandeur.
Yes. What else?
They could be violent too.
Yes, they're very high risk for violence in manic patients. What else?
Flight of ideas, reckless behavior.
Mhm. What about their clothing? Are they gonna dress normally or inappropriate attire, I should say?
No, appropriate.
Right, it's gonna be a little crazy. They might have a lot of colors going on and it definitely wouldn't look appropriate for the scenery. What about they're easily distracted, they're also very competitive, they're they're all over the place. They're gonna speak really fast. They're at risk for violence, as someone said. And another really important thing is setting limits with these people because they might not be able to stop when they start something. So how can we set limits, or how do we set limits as a nurse?
Well, we would tell them what is deemed appropriate and what is deemed inappropriate and make sure that they have an understanding of that.
To add on to that, setting boundaries and the consequences of their actions.
Reorienting them.
Yes, yes.
Also, we have to take into consideration their diet because they're always on the move. So we have to we could give them
like finger foods that they could eat on the go, because they're not gonna keep in one place to eat. So their diet is a major.
Yes, those are all really good things. So we want to identify what's appropriate, inappropriate, tell them the consequences of the inappropriate behavior, and then follow through, which you said is the most important thing. Like we tell them, if you don't cut it out, you're not going to be able to go back into the day room. They're not going to be allowed to go back into the day room if they keep acting inappropriately. Like we said, at when it's closing, they also have decreased concentration, so they can't really make decisions, excessive makeup and attire, they might like to undress, so we have to be careful with that. But something, as Anne said, that was really important that Dr.D mentioned was finger foods, right? Because they're always on the go. They might be too busy to shower, so we want to try to make sure we can get them to get their hygiene in, and decrease stimuli, right? So we don't want all these lights in the room, all these things. We want to decrease it because they're just so energized. You know, they don't have time to sleep, eat, or do anything. We don't need all these extra things in the room. So with that also, what are some interventions that we haven't mentioned that we could do for a patient, especially when they're violent? Like, what should we do if a manic patient becomes potentially violent?
We want to try to de-escalate the situation.
Okay.
Get help, like never try to manage them by yourself.
Okay. Those are all really, really good. I was also thinking things like we don't want to indulge in that behavior. We don't want to say that it's okay. And I think, as we all really said that was really important, was that never leaving them alone and never managing them alone, right? If they're violent, we don't want to approach them. We also don't want to be hostile when we approach them, right? We want to de-escalate it by trying to approach them calmly with someone with us and try to, because we always have to think about safety, trying to get them out of the situation that's could potentially cause them harm. That's why we also don't want them to participate in competitive-like activities because they're competitive naturally. Okay, so new things that she wanted us to add were some interventions for children or people with autism. So something that I had from the slides is that long-term outcomes of children with autism are improved with early identification and treatment. Right, so the earlier we can do something, which I think stands for all sorts of illnesses, the earlier you can get those interventions, the better it will be for the patient in managing their symptoms. Other things that we want to do is they have screening tools for these children, but they're usually used when they're toddlers or infants. And screening for prodromal or early symptoms in infancy helps mitigate some of those more debilitating features of this illness as they get older. Things I added that I didn't necessarily see her put, but these were the only things that were in the mental health outline, so I figured it would be important to include them, are that the diagnostic criteria is usually put 4-3, and it's most common in men. Symptoms include that they don't really connect with people, they more connect to objects. They have echolalia. Does anybody remember what echolalia is?
Repeat.
Yes.
Words.
Yeah, sorry, go ahead, Denise.
Repeat speech and
And they also have ecopraxia. What is that?
repeat.
Like, sorry.
Repeat movement.
Yeah, so they don't really, so I guess the major points when it comes to this is that they have trouble connecting with people, and they can also have things like echolalia, which is repeating the speech, or ecopraxia, which is repeating the movements. Then she also wanted us to know attention deficit hyperactivity disorder. And she said to know from one of the slides that the main characteristics that healthcare practitioners, including school nurses, differentiate ADHD from bipolar disorder are the pervasiveness of the symptoms and the predominant symptoms. So I think this is just a nice way of saying that we really need to know the three main symptoms, because that's what's going to help differentiate from other sorts of disorders. So the three main symptoms are inattention, hyperactivity, and impulsivity, or the you just kind of think. You do things without thinking. So that's something that is a symptom that we see in ADHD that is distinctive. So those are the three main symptoms. I definitely think she can ask a question like, what are the three main symptoms? And this would be it. The diagnostic criteria is usually before age of 6, and they usually do it in 2 settings. So for the children, it's the home and the school, and if it's for an adult, it's in the home or work environment. She also said to no medications. So I remember we went over some of this. So when I went over the mental health outline last week, but I'm going to repeat it again. So we give psychostimulants because they have a paradoxical effect, or in other words, they cause the same sort of energized effects that they would get in this during the symptoms of the disorder. So as a result, it helps mitigate them and they become more focused. And the common ones that we give for children are Ritalin, which I wrote the generic and the brand name. So the generic is methylphenidate, Ritalin, or Concerta, which is I don't know how to say these, but these two, these two drugs, Ritalin and Concerta, are the ones that we give for children. They're also controlled substances, which means they're highly abused. She also said for Concerta, what we should know is that it's a long-acting and it's given 1 time a day, and the school nurse should know that. And other considerations when giving this medication include do not give this medication after 6 p.m. Like I said, it does have a paradoxical effect, but if you're giving them something that's going to increase their focus and their stimulus, it might start to work later in the day and keep the kids up. So no. So not after 6. It can cause insomnia. We want to have a growth and development chart on hand because these 2 drugs can affect their growth and development, so we want to monitor that. It can affect their blood pressure, and we want to look at their blood work. We also want to set limits, which we already went through the steps of setting limits, what is appropriate, what is inappropriate, tell them the consequences if the inappropriate behavior continues, and then following through. Adults with ADHD can take medications like Adderall or amphetamine / dextroamphetamine salts, and I don't know how to say that one, but Strattera. And those are also controlled substances that are highly abused. So she said definitely know these things. That was from the mental health outline that I also typed that is on the GroupMe chat. It's available, but I copied it and put it onto here. And if you all want access to my typed version of this, I don't mind. But, okay. So any questions with anything?
No, so far so good.
Okay. So now we're going to go, we're already at halfway. We're doing pretty good. Now we have the school health. So the role of a school nurse. So we have 3 different roles: health assessment, health educator, and emergency preparedness, right? And as I said, we're a community health nurse. So we should be thinking one of the populations for sure is the community. And if they're a school nurse, it might also be the school community. So a health assessment includes the individual, the community or the population, the school health needs, but also health promotion. Because as we said, as a community nurse, the 3 things are health promotion, reduce risk, and also prevent disease and disability. So if one of our objectives is to promote health, that's also what a school nurse does. Health educator, nurses are educators, but a school nurse also educates, right? Like when we were talking in class, some school nurses have been so helpful and they taught children things about their asthma or how to use their pumps. So they're really good at helping children manage some of their symptoms or understand why they take certain things. And emergency preparedness, right? School nurses need to be prepared if there's a school shooting or something. I think more than ever, a lot of these precautions have been implemented with a lot of things that's been happening on the news. And that's one of the school nurse's role, is to be very prepared for an emergency and what to do when an emergency arises and have a good response and a recovery plan. I also started typing from the ATI book because like I said, I like having everything in one place. It's just a pet peeve of mine to look at different things. But she wanted us to look at, correct me if I'm wrong, I went to page 44 and it said to go to the roles of the school nurse, and the only thing that I saw in terms of the role of the school nurses were the different school roles in which a nurse can have. and it was these. I don't know if anybody had anything else that they thought to add, but that's what I found for that section.
That's all I saw as well.
Okay. So basically I was trying to like understand these better because there's like a lot of names here, but the case manager is the person who coordinates the services. So they get the things together. They make sure that if this person needs a doctor's appointment, they're going to set up a doctor's appointment. The community outreach is where it strives to meet all the needs of the school-age children by basically working with the community and education students. So remember, school health nurse, we're talking about community, and the community is the school. So the community outreach would be the community, but also the school needs. A consultant is someone who helps like gather the information. So I feel like the question could be like, a nurse is gathering information about, let's just say, a health service, and it's also helping them make the best decision. That's what a consultant does, like kind of helps you get the information and make decisions with the information that you have. The counselors are support systems for the students. So I think about our counselors at the school, how we have counselors that help other students by providing support and just places to speak and rant. So I think that's how I like to think about the counselor role for the school health nurse. There's also direct caregiver as a role where they actually are providing care to the students, such as maybe, putting on bacitracin to a wound or something like that. We also mentioned the role as a health educator, so help teaching the families and the schools and personnel different things relating to health promotional needs. And also a researcher, right? So they can help look for things that increases the knowledge of the school. Is there anything anybody wants to add that helps them remember any of these terms? No? Okay. So next things are common health concerns. Now before we get into the list, I know sometimes there's a lot of things to memorize, but what are some concerns that just might happen in a school that relate to health?
Could be like substance use, smoking, stuff like that. Also, like sexual education in schools is important.
Using marijuana, bullying in schools.
Right? Yeah. Like a lot of these things. I think about as you said, drugs, especially nowadays, a lot of children or a lot of people I know that are even in middle school have like these vapes and these e-cigarettes, right? Teen pregnancies, STIs, nutrition, right? Especially, do they have the means to have good, healthy nutrition, right? Or are they suffering from an eating disorder, or they don't have enough food, so they're malnourished, right? We have to look at things like that. And violence. So there's a bunch of different things, right? Bullying could also lead to violence. And I've seen so many stories on the news about like poor children getting beat up and hurt by other students. So those are things that we could definitely see. And I definitely think what helps to think about, like, what's some things you might see in a school or things that might promote or just might happen in a school setting that's concerning. And I think that we were able to list some of these things is good because those are some of the things that are already on this list. Also, the school nurse is an advocate, right? So they should, to me, when I think of advocates, that they want to promote the needs of people, right? They want to stand up and make sure that whoever they're representing has what they need. So they provide education. Remember, for primary prevention, so as a school nurse, you want to educate and communicate necessarily to ensure that the students have their health and educational needs met, right? So we want to make sure our students are healthy. We want to implement strategies to reduce disruptions in the students' school activities. We want to communicate with families and healthcare providers as authorized. We want to ensure the student receives prescribed medications and treatment, and that the staff who interact with the student on a regular basis is also knowledgeable about these medications. It's good to know if a student is on a lot of things, right? Like sometimes you have students who have chemo treatments. It would be good to know if that student is still coming to school, what sorts of needs, if they might have to be excused to go do something or take a medication. It's good to know that. and provide a safe and healthy school environment to promote learning. So like I said, when I think of these things, sometimes it's hard to memorize a lot of things, but I try to think of it like in a way of the role as the community nurse and that I need to help my population and do the greatest number of good for the greatest amount of people. So I want to make sure, and I'm also an educator as a school nurse, right? That's one of my roles. So I want to educate and make their health needs met. I want to make sure they're able to perform in all their school activities. I want to make sure that they have their medications, know how to use their medications, communicate with who I need to communicate with at the appropriate times, such as families, and make sure everything's safe, right? Safety is always a priority for a nurse, whether it's community nurse or not. So those are some things that we do as a school nurse. I don't particularly have the handouts for the next thing, but is there anything that you want to add to the previous section, or is there any of these handouts that you want to go over before I move on? No? Okay, so like I said, I have the typed version. If you haven't received the emergency preparedness and disaster, please ask me, or it should be, Dr.D did post it somewhere. The hazards, don't forget she said to go in the textbook. I forgot what page, to look at that and write some in the back. And we have that as reference for the biologic, chemical, physical, and psychosocial. And we also are allowed to print out the ATI page 8, which is on the levels of prevention and all the different things that go underneath. So we are allowed to have all of those things. So we can have that with us on the exam, which is good. I definitely think the best way to just study with those things is just read it over a couple of times, get it like used to the information, not necessarily memorize anything because you're going to have it there, but you should be familiar with it and at least what it says. The next thing is the site walkthrough, which is something that she said we need to know from chapter 25. And a work site walkthrough is a survey which is a part of the whole workplace assessment. And the things that they should be looking at is, because they're like walking through, right? They're kind of looking at the place as a whole. So they're looking at the workplace processes and materials, like what's around there, right? Is any of that stuff that's around safe? What are the job requirements? Is there any hazards? The workplace practice, are they washing their hands when they come out of a patient's room? Are they not doing that? Are they disposing of things? Like what's going on here? The incidence or prevalence of workplace injuries. And they're also looking at strategies to eliminate exposures. And I know she wrote ATI pages 42 and 43, but the only thing that I saw when it came to ATI, she said, was just to know the site walkthrough. I don't know if anybody else has anything to add or if that's it.
No, that's all she mentioned for that page.
Okay, yeah. Okay. So the next thing is the community assessment. So the thing that she said us to know is the windshield survey, which is what we're doing, but we're not driving in a car. So the whole thing with this survey is to kind of be driving in a car, taking public transportation, and just driving around and seeing what's in the neighborhood and assess their strengths. Like, oh, they have a lot of local health clinics, but, oh, they have a lot of bodegas and they don't have a lot of supermarkets. So we're looking at what's going on in that area through a vehicle. That's what the windshield survey is. For community assessment asset-based approach, the way I think about this is they're looking at the positives of that community. What strengths, what resources, what good things does this have, right? Like in my community, I go to Brookdale, and they have a lot of local clinics. So that would be a positive. That would be using an asset-based approach because I'm looking at the positive things. Oh, wow, they have a lot of, like, little corner stores with information or things like that, a lot of public parks, whatever resources and things that promote, I think this is all a positive thing. So when I think of assets, I think of positives. And then the collaborative model is just a model that includes looking at the making an assessment based on looking at the interdisciplinary team and everybody else around you. So I think collaborative is like including people. That's how I would consider the collaborative model. So if there were a question, it's an assessment including the team and the community. Does anybody have anything else to add? No. Okay. So the next thing is the levels of prevention. So there's a couple. So what is primary prevention?
It's basically how to avoid an illness from occurring. So like immunizations, education.
Exactly. Education, immunizations, because they don't have an illness yet and we want to prevent any illness or even an injury. What about secondary prevention? What is secondary?
It's like screening, getting screening, assessment, physical assessment, screening like getting a mammogram, you know, taking care of yourself before, getting the illness. I mean, it's doing screening.
Also, community organizing is secondary.
Making sure to do regular exams. So screening test is it's supposed to have detect diseases in its earliest stages. So you want to catch it early.
Correct.
Yeah, it's exactly like all of that. So they may or may not have it, but they could, unlike primary, they could potentially have early stages of a chronic or acute, but we do screenings or physical assessments and things like that to identify potential symptoms. So if it were in the school per se, secondary would be like if a kid fell because now they have an injury, but it's like a minor injury because they might have just scraped or cut their knee. So it's things like that. And what about tertiary prevention?
I would say it's steps to bettering someone's like way of life after they already have a problem or an injury. So like rehab or support groups or things like that.
Mm-hmm. Providing counseling.
Yeah, it's basically managing what symptoms they have. Because now in tertiary, they already have the chronic illness or the acute illness. It's there. Like they might have diabetes. So now the things are, okay, let's give them things like medication, adherence strategies and things like that, helping them manage these things or things they might need to do to care for themselves while having this disease. So yeah, there could be, I guess you could say, some sort of education, but it's not the same way. The education in primary is prevention education. This would be like they have a disease and they need to manage their symptoms. Okay, so the last section is just on culture. So how would you all define culture?
It's like shared values within a social group.
Yeah, it's knowledge, values, practices, customs, and beliefs of a group. And the properties of a culture include that it's dynamic, meaning it's changing, it's shared, it's not private, and that it's learned, right? We learn our cultural practices from the people we're surrounded by, and pretty much that's our family. So we learn our cultural beliefs and our values. So those are some things that she said she wanted us to know. Also, for the next category is cultural competence. So the definition of that is an attitude of openness to respect for and curiosity about different culture, values, and traditions, and ideally includes a broader critical analysis of power relations affecting health disparities. For community health nurses, it necessitates familiarizing oneself with cultures that are represented in communities they serve. For me, when I was reading this, I feel like cultural competence means that you respect other people's cultures and you're able to listen to them and you actively try to learn about them. That's kind of the way I took it. I don't know if anybody else has anything to add for cultural competence.
I remember she made it clear, never assume one culture.
Yeah, that's definitely, we should not do that because no culture is the same, and even though someone might practice something in one culture and you have a patient of identifying with the same. They might just have different practices. Also, speaking of that, cross-cultural nursing is another definition she wanted us to know, which is any nursing encounter in which the client and the nurse are different cultures. So cross-culture just means my culture and your culture are different. And ways that we can institutionalize cultural competence or otherwise include it in like a curriculum would be, she said to know 2 slides, cultural competence 1 and then institutional cultural competence 2. And the first one said for community and public health agencies to be culturally competent, they must have a defined set of values and principles and demonstrate behaviors, attitudes, and policies and structures that enable them to work effectively across cultures. So like I think of it as where different health and hospitals and agencies, they kind of have like modules and things about how to provide culturally competent care, about asking about beliefs. I think that's what that means. Like I know at NYU they have all those little modules about, you know, what to do if someone identifies with LGBTQ or someone who's a different culture. You're giving you steps on how to sort of break those barriers, but also try to make sure that the care that you're providing also aligns with the care that they need. And it also says that in order to institutionalize cultural competence, we must have the capacity to value diversity, conduct a self-assessment, manage the dynamics of difference, acquire and institutionalize cultural knowledge, and adapt to the diversity and cultural context of the communities they serve. Does anybody have anything else to add?
No.
Okay. So the next definition she said to know was cultural humility. So I took this definition as the opposite of ethnocentrism because the definition is an acknowledgement that everyone's views are culturally influenced, that our own are not inherently better than those of our clients, and that our clients can teach us. So the reason I say that because ethnocentrism means that it can be defined as an assumption that everyone shares your cultural values and that your opinion that your culture is superior or that your culture is essentially better. So I feel like culture immunity is saying like my culture is not better than anyone else's and that I can learn, whereas ethnocentrism is like, no, my culture is better than everyone else's. I don't want to learn from anyone. That's why I feel like they're opposites, and that's what helps me remember. And the ways that we can promote cultural humility is by asking open-ended questions about their beliefs. So what's an example of an open-ended question that we could ask a patient about their beliefs?
Like, tell me more about this or something like that.
I think one of the examples she gave was, tell me what it was like growing up, let's say, for example, in a Hispanic community or from not just a Hispanic community, but like, I don't know how to put it, but it was something similar to that she said.
Yeah, those are really good. We could also ask them about their traditions and their perceptions of what they think might cause an illness and how they have tried to address the illness. And like I said, we went over ethnocentrism, but I just feel it's the opposite because it's the idea that you believe that your culture and your values should be the dominant and they're more superior than others. So the next things that she wanted us to look at were Western biomedicine as cultured, and that slide just said that the first imperative of cultural competence is to be competent in one's own cultural heritage. In other words, like knowing your cultural beliefs and the things that you value. I think that's the most important thing. Even in the cultural assessment in the ATI book that I was looking through, it said the first thing you should do before even conducting a cultural assessment is making sure you do a self-assessment. Then there's also aspects of culture directly affecting healthcare. So things include like attribution of illness. But what are some other things that could affect healthcare that are related to different aspects of culture? Like what are some cultural things that can affect healthcare? Can diet be something that can affect your healthcare?
I think so.
Right. Can also your religion affect how you get healthcare? Because as in some religions, They might not be allowed to have alcohol-infused products or pork products and things like that. So it's like you need to know these things because it affects how they receive care or what sorts of things they can eat or take into their body. Some people don't believe in medication. Some people believe in herbs and other things. So it's definitely really important to know that there's different things. So some of the things include attributions of illness or what causes an illness, diet, verbal communication and nonverbal communication, right? Some cultures like when you give eye contact, some don't. Some don't want you very close in their personal space. Some cultures might feel in order for you to have a good conversation, you need to be close. So everybody's different. Different styles of communication. People have different ideas of time, right? Some people, and this is what ATI said, time orientation means some people live or view things in the past, present, or future. So if they said a lot of clients who view things in the past or the present might not really be so keen on adhering to healthcare regimens because of the fact that they're focusing either on the past or the present. They're not looking towards the future. People who might say, oh, I look towards the future might say, I want to take care of myself now to prevent something that could happen years down the road. Different roles, right, like family roles or who you go to for healthcare decisions. When I was doing the assignment for geriatric, I learned that in the Japanese culture, something that's very prominent is that the family makes decisions for you, and it's especially when you're older. So that also might be a big factor in the healthcare of that patient because in that culture, we have to go by the family's preferences. If that's what the client says, that's how their culture practices. And like I said, different sorts of folk medicines like herbs and things like that. That's why we want to ask about that. She also said to look at the pages 13 to 15 in the ATI book. I mean, I could either review that now with you because I just kind of wrote out what it said in the textbook, or if you want to read it on your own, it's entirely up to you all.
We could go over it.
Okay, yeah, we could finish. It's only like one page.
That's fine with me.
Okay. So basically, I didn't get to write the interpreter part, so that part you'll have to read, but I did know she said with interpreters you should not have the families because it's a risk of confidentiality, and they also might not necessarily repeat back everything that their family member or the person they're interpreting for said, and we also don't want the interpreter to have the same culture as the patient that they are interpreting for. I know those are some things that she said, but I just don't have it written down. But cultural competence, which is something we went over before, but ATI defines cultural competence is a skill the nurse develops in learning to respect the individual dignity and preferences as well as acknowledging cultural differences. So like I said, I think this is all a respect. And I think the key thing is she might even include that in like a definition base, like that it's a skill that you learn, right? It's something you learn to be culturally competent, or in other words, understanding different people's cultures and being open to learning about them, because you don't learn, as she said, all the cultures overnight. So I think the important word here is that it's a skill. Also, she identified cultural sensitivity as awareness and appreciation of values, norms, and beliefs characteristic of a cultural, ethnic, racial, or other group that is not one's own, accompanied by a willingness to adapt one's behavior. So I think this is another way of saying being culturally sensitive by doing things or saying things in a way that appreciates their values and their norms. So ways to convey cultural sensitivity according to ATI include addressing the clients by their last name unless given permission to call them another name, introduce yourself and explain your role, be authentic and honest about what is known and not known about a client's culture, use culturally sensitive language, find out what clients know about their health problems and treatments, and determine the client's intent to adhere to the prescribed medication or treatment plan. Incorporate clients' preferences and practices into care when possible. Do not make assumptions about the clients. Encourage the clients to ask about anything that they might not understand. Respect clients' values, beliefs, and practices. Show respect for clients' support systems, and provide help teaching materials in the client's primary language and the recommended readability level. So that's ways that we can be culturally sensitive. Like I said, I think that's just the idea of like being aware of what you're saying and making sure that the behaviors that you attribute and the care that you provide is also aligning with their beliefs, or at least respecting them. So the cultural assessment is what she wanted us to know too, and there was different parts. So the cultural assessment provides information to the healthcare provider about the effect of culture on communication, space and physical contact, time, social organization, and environmental control factors. So we need to know their culture because we can only provide the best care when we know what sort of practices they can and cannot do, or things that we're not allowed to do because they might go against their cultures or their beliefs. And as I said, really important, prior to collecting information about a client's culture, the nurse should perform a self-assessment and ask the following questions to themselves. Am I aware of my culture and my views about other cultures? Am I able to perform a culturally sensitive assessment? Do I have knowledge necessary to develop culturally appropriate nursing interventions? What is my goal in learning about diverse populations? And I think even if I can't remember all of these questions, I would say my first question is like, am I aware of my own views? And then my next question is going to be, will these views, or am I able to perform culturally competent care? And then the next category is environmental control. So basically in this section, it says that some individuals believe that the environment can be mastered. In other words, they believe that they can do things that can alter the environment, or the environment can be altered so that they can promote and they can engage in health promotion activities, disease prevention and treatment. So these are the type of patients that would adhere to a medication regime. Whereas individuals who believe in harmony with the environment or believe in letting nature sort of take its course might not necessarily use solutions that Western medicine might use. They might use herbs or just maybe let their body heal. So that's something that they were talking about with the environment. Time orientation is what I mentioned before. An individual might focus on the past, the present, or the future. Individuals who focus on the past or the present can have little interest in health promotion behaviors, which are described as having a benefit in the future. Other things are the social organizations, right? It describes the family members, or just the family as a whole, anybody that the individual finds significant, and that affects how they make decisions. Sometimes decisions that a client might make about their health may be by an individual that's not in their group or in their family. It could be like a healer, someone they go to help make decisions on their behalf. Everybody's culture is different. So the nurse should plan to include teaching and decision making that the client dictates would be important to that process, whomever that healthcare should be directed to. The nurse should also understand the client might make decisions based on the greater good of the family. Like I said, one culture is a Japanese culture that I read about in the geriatric textbook that would make the needs be met of the family rather than themselves. So they would go to the family for what I should do for my health instead of the nurse going to the patient saying, what should I do for your health? Some cultural assessment parameters include their ethnic background, their religious preferences, their family structure, their language and literacy needs, communication needs, education, cultural values, food patterns, health promotion and maintenance practices, types of health practitioners used, medicines, remedies, treatments, and therapies used. Lastly, there's steps of data collection. So the first step of the cultural assessment is collection of self-identifying data about the client's ethnic background, religious preferences, family structure, food patterns, and health facts. The way I think of this is before you do an assessment, right, they said the priority is looking at myself, looking at my own values, and evaluating that. After I do my own self-assessment, then I go and do a cultural assessment, or I ask them, tell me about your beliefs. Tell me about what you believe in and what sorts of practices should I know. What are your food patterns or things like that. Then, after I ask myself and then I ask them about their cultural beliefs, we should ask about their perceptions of healthcare and their health needs. How do you perceive your health? And then lastly is, how those cultural factors that they told us about and how they perceive their healthcare, how is that going to affect the nursing interventions? So I feel like in summary, it's you first look at yourself and your cultural beliefs. Then you look at the client's culture. Then you find out their perceptions of health and what that means to them and how they meet those needs. And how are those cultural values and their perceptions of health going to affect my interventions as a nurse? Is there anything that anyone wants to add that I missed maybe? Like I said, I just didn't get to type the interpreter part.